Welcome back to Mapping Healthcare on KDRT 95.7 FM in Davis, California, where a medic with a map explores healthcare around the world, highlights people who improve it, and shares what we can learn from them. This is your host, Dr. Sheikh. Today we're talking about something that feels a bit counterintuitive in a hospital setting: taking risks. I don't mean being reckless with a scalpel. I'm talking about intelligent risk-taking, the kind that allows us to challenge the status quo to make healthcare safer. Let's look at a patient, Sarah. Sarah was preparing for a colonoscopy. She went through the whole prep, which, let me tell you, is nobody's favorite thing to do on a Saturday night. The hospital spent the resources and the staff were ready. But right before the procedure, the specialist finally reviewed her case and realized she wasn't a candidate for it. The procedure was cancelled. On the surface, it looks like no harm, no foul, right? But Sarah went through unnecessary discomfort and the system wasted precious time. This is what we call a process failure. In many hospitals, the low-risk move for a nurse or a resident is just to keep their head down and finish the prep. The intelligent risk would have been for someone to speak up earlier and say, "Hey, does this actually make sense for this patient?" Today, we're looking at why that kind of risk is so hard to take, how our history with medical errors has evolved, and how we can move from just fixing the problems to improving systems. To understand where we're going, let's look at where we started. The 1999 report to Err is Human was a watershed moment. I was in my second year of pediatric residency in New York, and it really influenced the direction of my career as a physician. Before that report, things like hospital-associated infections were often just seen as the cost of doing business. The report changed everything. It told us that errors are common, costly, and most importantly, usually caused by system problems, not just bad clinicians. We entered what's been called the Bronze Age of patient safety. This was the era of the bundle and the checklist. We learned that by following a specific bundle of procedures, you could reduce dangerous problems in hospitals like central line infections to nearly zero. But even with these tools, progress has been inconsistent. We found that you can give a team a checklist, but if the culture is one of blame, people will just cram for the exam before an inspection from a hospital accreditor or a regulator, and then go right back to their old habits once the surveyors leave. We're now trying to move toward a golden era. This involves becoming high-reliability organizations. Health systems that operate in high-risk environments but achieve consistently safe performance. This change requires moving from safety 1, which is just trying to make sure as few things go wrong as possible, to safety 2, which is learning from what goes right in everyday practice. Our guest in today's episode of Mapping Healthcare is Dr. Joan van Vliet, the CEO of Qual Europe, based in Utrecht in the Netherlands. She is also president of the International Society for Quality in Healthcare. The views expressed on this show are mine and those of my guest. So Joan, welcome to Mapping Healthcare. You are the CEO of Qual Europe, and it's a non-profit organization that helps improve and assure the quality and safety of healthcare through assessment, accreditation, certification, training, and support programs. And Qual works with over 130 healthcare organizations in the Netherlands, Belgium, and the wider European region, including hospitals, mental health services, elder care, home care, independent treatment clinics. And then in addition to that, as I mentioned, we interact on a regular basis through the International Society for Quality in Healthcare work that we do. So you have a long and illustrious path in healthcare improvement. So start us at the beginning. Tell us briefly about your career path to what you do now.
Thank you, Ulfa. First of all, it's so nice to be here. But let's start at the beginning. And I started my career in healthcare as a nurse. And I've been working as an operating department nurse for 10 years. And in these years, I was also a head teacher in my hospital for theater nurses. And it was here where I found my passion in healthcare. How can you make it easy for care professionals to deliver good quality care from the perspective of your patients? And then I got a master's degree in health economics and management, studying in the evening hours while doing day and weekend shifts in the operating department. And then I continued with a PhD study in the Rotterdam Eye Hospital. And we implemented lean care pathways and we investigated the effects on efficiency, staff engagement, and patient experience. And I would like to share the most important finding. And that was what most influenced patient experience. That was expectations management and patient education. So the patients who understood what would happen and why reported the best experiences. And that made me realize that the lens that we use is first and foremost our own. And it takes self awareness to put yourself in your patient's shoes and truly empathize with them and see the care pathway from their perspective. But in the meantime, I continued working and I worked as a nursing director and as an executive director in several hospitals. And the last job I did before moving into my current position is supervising a merger between two large teaching hospitals. Very dynamic project that taught me the importance of creating a mutual understanding of what putting the patients first actually means when you have to make many complex interdependent decisions. And that was a great experience. And here I am today, CEO indeed of the accreditation body in the Netherlands and in Belgium, and also president-elect of ISQA. And quality in healthcare service is still the cornerstone of my work.
Several things stood out from what you told me, and a couple of those are your background as a clinician, and we see that as the root of many healthcare improvers' pathways, that they start off in their work as clinicians, but then they take an intelligent risk, deviating from a traditional one-on-one patient care background is a little bit of risk, but you had the self-awareness to understand that that needs to be your career pathway. And that is central to the theme of our conversation today. We're talking about intelligent risk-taking in the broader healthcare setting. So healthcare is traditionally a risk-averse field, and I understand that really well since we have high stakes there, and there are inherent risks in the work that clinicians and frontline healthcare providers do. But deliberately trying new evidence-informed approaches that may improve patient outcomes, system performance, or help us innovate while actively managing potential harm, that's really central to moving forward in healthcare. So what sorts of barriers, either cultural barriers or the way the healthcare system is set up, what sorts of barriers most prevent innovators and clinicians from taking smart risks that could improve healthcare?
Oh, wow. Yeah, healthcare is by design a risk-averse field to protect patients. And the same structures that keep safe care safe can make it incredibly difficult for clinicians and innovators to take smart, intelligent risks that could actually improve care. And the biggest barriers are a mix of cultural norms and structural constraints. So, first, regulatory and compliance pressure. Healthcare is one of the most heavily regulated sectors, and for good reasons. But the unintended consequence is rigid processes, fear of violating standards, and little flexibility to test new approaches. And in many systems, even small errors can trigger investigations, reputational damage, or disciplinary action. And when the personal risk feels that high, people avoid experimentation. And second, a deeply ingrained culture of perfectionism. Clinicians and care professionals are trained to avoid mistakes at all costs. And that creates fear of being wrong, reluctance to try new methods, and a belief that safe means doing things exactly the way we've always done them. And on top of that, performance metrics often reward efficiency, adherence to protocols, and minimizing variation. All things that discourage controlled experimentation, even when variation could lead to better outcomes. And third, the hierarchical and siloed structures. Traditional hierarchies can silence the very people who see the problems most clearly: nurses, junior clinicians, allied health professionals, support staff. So innovation suffers when only senior voices are heard. And add to that the fact that healthcare systems are often fragmented across departments and organizations, and it becomes incredibly hard to test ideas that cross boundaries. So when you put it all together, failure, punitive systems, rigid regulations, hierarchical cultures, and a lack of time and incentives, it's no surprise that smart risk-taking struggles to take root. So the challenge for all of us is to protect patient safety while creating conditions where thoughtful, evidence-informed experimentations is not only allowed but expected.
Yeah, and you spoke about so many issues there in the way we do our work in healthcare. I joke that I'm a recovering perfectionist, but really that element of being a perfectionist is what helps me keep my patients safe, right? Like when I double and triple check my work, when I make sure that everything is exactly and precisely done the way it needs to be. So that's a fine balance between trying to make sure everything is done right and then overdoing it to the point where innovation is affected. So, with intelligent risk taking, we're not just talking about reckless experimentation. Instead, we're trying to balance innovation with patient safety. We're trying to balance clinical judgment with data and balance courage with accountability. We often talk about urgency in healthcare, whether it's urgency in giving patients access to care, urgency in trying to handle the stress and burnout in healthcare, or the urgency of trying to keep pace with the growth of scientific discovery. So, which urgent need do you believe requires the boldest action right now, and why is that so?
If I had to choose one urgent need that demands the boldest action right now, it's the human crisis in healthcare, the state of the workforce. We talk a lot about access, equity, digital transformation, scientific breakthroughs, but none of those priorities are achievable if the people delivering care are exhausted, leaving the profession, or working in systems that make it hard to do their best work. So burnout is no longer an individual problem, it's a structural one. The pace and complexity of care are rising faster than teams can adapt, and that puts both safety and trust at risk. And when clinicians don't have the time, support, or psychological safety to learn, collaborate, and innovate, the entire system becomes fragile. So bold action means addressing root causes, not the symptoms. It means redesigning workflows to reduce unnecessary burden and investing in team-based care, creating environments where people can learn and improve quickly, and treating workforce well-being as a strategic priority and not a wellness initiative on the side. So, because if we don't protect and strengthen the workforce, every other ambition in healthcare, equity, access, innovation, safety, it becomes impossible to achieve.
The words you said just now really spoke to me because I'm a frontline practicing clinician and live the life that you just described. Something else you said really is key here, the concept of psychological safety. So, psychological safety is the shared belief among members of a team, whether that be a healthcare team or in any other work setting, that the environment they work in is safe for risk taking. And that allows people to speak up, ask questions, report problems and mistakes, or propose new ideas without a fear of punishment or humiliation. And psychological safety is a critical driver of innovation, really highly performing in an organization, and overall well being, concepts that you really articulated here. So, how can leaders in healthcare create an environment where their teams feel empowered to risk take, to experiment, to fail safely, and learn quickly without adversely affecting patient and clinician trust or safety?
Well, leaders can absolutely create environments where teams feel empowered to experiment and learn quickly without ever compromising patient trust or safety. And the key is finding the right balance of freedom, structure, and psychological safety. So, first, leaders need to create what I call freedom within a frame. Teams should know exactly where they have room to innovate and where the boundaries are non negotiable. When leaders define clear safety standards, clarify what can be experimented with, and set guardrails that protect patients, teams gain the confidence to try new ideas responsibly. And second, Leaders must build psychological safety, and people only take smart risks when they feel safe to speak up. And that means inviting questions and doubts, responding constructively to mistakes, and modeling humility and curiosity. And when leaders show that learning matters more than being right, experimentation becomes a shared norm rather than a personal gamble. And third, leaders need to make learning more important than perfection. So innovation doesn't require big leaps. It thrives on small, low-risk tests, micro experiments on a single shift or team, rapid evaluation cycles, and scaling only when something works allow teams to move fast while keeping patients safe. So when leaders celebrate insights, treat failures as data, and encourage reflection after every test, failure becomes safe and learning becomes continuous. So leaders create empowered safe experimentation by combining clear boundaries, psychological safety, small tests, transparent communication, and a culture where learning is valued above perfection. That's how you protect patient trust while accelerating improvement.
And a key part of that is what you mentioned about moving the onus from individual clinicians and making this the responsibility of leaders in healthcare. And talking about leaders, you are the president elect of ISQA. And from that vantage point, you have a global view of healthcare. And as you know, healthcare environments are complex and they're rapidly changing. And without some degree of tolerating risk, health systems can become stagnant. They can become overly defensive, resistant to improvement. So, what role should data and technology, these days we have AI, predictive analytics, digital health tools. So, what role should technology and data play in guiding which risks are worthwhile to take? And where do you see some of the biggest opportunities and pitfalls here?
Well, data and technology, whether it's AI, predictive analytics, or digital health tools, should play a crucial role in helping us understand which risks are worth taking, but they should guide our judgment, not replace it. So, the biggest opportunity is that these tools can help us see patterns, anticipate risks, and identify improvement opportunities far earlier than humans can on their own. Predictive analytics can flag patients at risk before deterioration occurs. AI can surface variations in care that might be worth exploring. And digital tools can give teams real-time feedback so they can test small changes safely and quickly. And in that sense, technology becomes a kind of safety net that supports responsible experimentation. But there are also real pitfalls. One is over-reliance, assuming that if the algorithm says it's safe, it must be safe. And another is bias. If the underlying data reflects inequities, the technology will amplify them. And there is a risk that tools designed to support clinicians end up adding burden or complexity instead. And they call that the productivity paradox. So the role of data and technology should be to inform, not dictate. And they should help leaders and teams decide where experimentation is low risk and high value, and where guardrails need to be stronger. So the biggest opportunity lie in using these tools to accelerate learning, personalize care, and spot early signals. And the biggest pitfalls come when we forget that technology is only as good as the data, the design, and the human judgment around it. So in short, data and technology can make smart risk-taking safer and more precise, as long as we use them as the handy tool in decision-making and not as a replacement for clinical wisdom and patient trust.
Yeah, and that is a really excellent point. And we've seen that, some risks in healthcare, like changing clinical care pathways or implementing new technologies, can leave out underserved communities. And we saw that when telehealth rapidly evolved and expanded during the COVID-19 pandemic. But people without reliable internet devices or digital literacy were left behind. So, how do we ensure that our innovation and risk taking does not widen health disparities?
Well, when we talk about innovation in healthcare, we have to acknowledge a hard truth. And that is that some risks, like redesigning care pathways or introducing new technologies, can unintentionally widen disparities if we are not careful. So the challenge is not just how we innovate, but who benefits from that innovation. And to ensure that innovation is equitable, we need to build equity into the process from the very beginning and not as an afterthought. So, first, we need to involve the communities most affected. Vulnerable groups should have a voice in shaping new models of care and not just experiencing the consequences. And co designing with patients, families, and community partners help us understand real world barriers and prevent well intentioned ideas from creating inequities. And second, we need to use data to identify who might be left behind. Equity-focused analytics can reveal whether a new pathway or technology works equally well across different populations. And if early signals show uneven impact, we can adjust before scaling. And then data becomes a tool for protection, not just prediction. And third, we must ensure access is part of the innovation strategy. Like you said, a digital tool that requires high-speed internet, English fluency, or advanced health literacy will systematically exclude the very people who often need support the most. So innovation should reduce friction for vulnerable groups and not add new layers of complexity. And finally, we need to be honest about the risks. Every innovation should come with an equity impact assessment. Who benefits? Who might be burdened? What safeguards are in place? And leaders have a responsibility to slow down when equity is at stake and to build guardrails that prevent harm. So the goal is not to avoid risk, it is to take smart, responsible, equitable risks. And then innovation should narrow disparities, not widen them. And that only happens when equity is treated as a design principle and not downstream correction.
Yeah, and so we spoke today about how intelligent risk taking in healthcare involves thoughtfully pursuing new things, but intentionally balancing benefits against risk, right? And making sure that patient safety and ethical responsibility remains at the core of what we do. So now let's look ahead 5 or 10 years. What area of healthcare do you think requires the boldest bets today? Like, for example, what's one risk that you wish more people in healthcare were willing to take?
Well, if we are looking 5 to 10 years ahead, the area that requires the boldest bets today is rebuilding and reimagining the healthcare workforce. Not just staffing levels, but the way teams work, learn, and adapt. Every major challenge we face ultimately depends on whether we have a workforce that is supported, empowered, and able to keep up pace with change. If we don't take bold action now, we risk a future where we have extraordinary science, but too few people able to deliver it safely and compassionately. And one risk I wish more people were willing to take is to redesign care models around relationship based, flexible, and technology supported teamwork, rather than trying to preserve traditional roles and workflows that no longer match the complexity of modern care. And that means experimenting with new staffing models, new scopes of practice, new ways of sharing responsibility, and new approaches to learning in real time. And it's a risk because it challenges long-standing norms, hierarchies, and professional boundaries. But it's also the most necessary risk because without bold redesign, we'll continue to burn out the people we rely on most. So the boldest bet we can make today is investing in the people and the systems that allow them to thrive. And if we get that right, we avoid tomorrow's crisis and unlock the capacity for every other innovation we hope to see.
So that is such an excellent point. Keeping the workforce at the center of what we do and making sure that the workforce is thriving. And talking about thriving, Ellen Joan, it's been such a pleasure talking to you today because I can see how you will continue to keep ISQA thriving. You have those strong relationship building skills in terms of making sure that everyone is engaged and moving our work forward. And also, talking about thriving, You work in a thriving city in the Netherlands, Utrecht, and we end each episode of Mapping Healthcare by talking a little bit about the place our guest comes from. So tell us a little bit about a couple of experiences or activities that a person new to Utrecht should check out.
Oh, that's a very nice question, Ilfat, because Utrecht is one of the Netherlands' most picturesque cities with a nice and relaxed vibe. And when you can spend a day or two in the Netherlands, catch a train from the airport, and within 30 minutes, you're in the center of Utrecht. And then stroll along the scenic old canals with medieval wharf cellars that now house cafes, boutiques, and bookshops. Or climb the Dom Tower, and that's the iconic symbol of Utrecht, and the tallest church spire in the Netherlands. But Utrecht is also the birthplace of Miffy, the beloved children's book character. So look out for Miffy statues around town or visit the Miffy Museum. And of course, you can also come to my office in Utrecht and visit me for a nice cup of coffee.
That sounds delightful, Ellen Joan. And being a pediatrician, children's books are always at the top of my mind. And I haven't checked this one out. So I am going to look up the latest collection of Miffy books and check them out for sure myself as part of my homework of being a good pediatrician. So that was Dr. Ellen Joan van Vliet telling us about how innovators and clinicians can take smart risks that could improve healthcare. So if we have the checklists and the data, why is healthcare improvement still so hard? In a study of nursing units, researchers expected that the best teams, the ones with the best leadership, would have the fewest errors. The results were the exact opposite. The best-led teams reported more errors. Why? Because they felt safe enough to talk about them. In the teams that reported the least amount of errors, the interpersonal climate was so oppressive that people kept their mistakes to themselves. This brings us to the concept of psychological safety. The belief that you won't be punished or humiliated for speaking up with ideas, questions, or mistakes. Without the safety, people fall into the trap of first-order problem solving, or what we usually call workarounds. Think about a nurse who needs a specific supply, but it's missing from her unit. She takes the risk of sneaking over to the next unit to borrow it. She's a hero at the moment because the patient gets cared for, but the underlying system problem, the broken supply chain, is never fixed. In fact, she's made it worse for the next unit. Second-order problem solving is the intelligent risk. It's when that nurse doesn't just grab the supply, but also tells her manager, hey, we're consistently missing this item and it's slowing us down. It's a risk because it takes more time and might feel like complaining, but it's the only way the organization learns. So as we wrap up this episode, here are some of my big takeaways from talking to Ellen Joan and researching this topic. First, deal with second-order fixes. When you encounter a glitch in the health system, missing medication, a confusing electronic health record alert, or a broken piece of equipment, don't just work around it. A workaround hides the problem from the people who can fix it. Whenever possible, flag the root cause to your leadership. Second, be a disruptive questioner. We're often trained to be adaptive conformers, the people who just get the job done without bothering anyone. But organizations can't learn without the disruptive questioner who asks, why do we do it this way? Is there a better way? That question is an act of leadership. And finally, build a just culture in your own team. You don't need to be a hospital CEO to change the culture. Psychological safety happens at the microsystem or local level. Whether you're an attending physician or a senior nurse, how you respond to bad news matters. If you embrace the person who brings you a mistake as a source of learning rather than a source of trouble, you've just made your clinic or ward much safer. Healthcare is complex, and the safest thing we can do for our patients in the long run is to take the interpersonal risk of being honest about our systems. Thanks for tuning in. This was your host, Dr. Sheikh. You were listening to Mapping Healthcare on KDRT 95.7 FM. Connect with the show on Instagram at Mapping Healthcare if you'd like to share your thoughts and ideas for future episodes or guests. You can hear Mapping Healthcare around the world anytime on kdrt.org and wherever you get your podcasts.